Good evening and welcome to Doctors on Call. I am Dr. Peter Nalin, Professor and Department Head of Family Medicine and Biobehavioral Health, Associate Dean for Rural Medicine, and co-leader of the Duluth campus of the University of Minnesota Medical School. I am your host for tonight's program on sports and outdoor injuries and joint replacements. The success of this program is very dependent on our viewers. Please call or email your questions, and we will do our best to address them. The telephone numbers and email address for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Patrick Hall, an orthopedic surgeon with Orthopaedic Associates of Duluth, and Dr. Carl Rasmussen, a family medicine physician with St. Luke's Mount Royal Medical Clinic. Members of the WDSE staff are standing by to take your phone calls. And now on to tonight's program. Our first question is from Duluth. Dr. Hall, what are the most common sports injuries?
Well, fortunately, most sports injuries are minor. They involve a lot of sprains and strains, and a lot of those can be treated conservatively with the typical home remedies with ice and elevation and compression and ibuprofen. A lot of those things get better with conservative management. But then some of the more serious injuries that can happen in sports are fractures and dislocations of the joints. So with some of the higher energy trauma that occurs in some of the more contact sports like hockey and football, we see all kinds of different injuries, and some of them are sports specific. But ACL injuries are common, ankle sprains and fractures are common, shoulder injuries are common in sports like hockey where there's a lot of checking, so they range all the way from fractures and dislocations to shoulder separations. And again, a lot of those injuries can be treated non-operatively, but some of them require surgery and some of them needed to be attended to more urgently.
Thank you. Dr. Rasmussen, help us understand the difference between a sprain and a strain.
Yeah, it's mainly a terminology difference. A strain is referring to muscle tissue or a tendon injury, and a sprain is a ligamentous injury. As Dr. Hall was discussing, these are non-operative or injuries that can be treated conservatively. And most of them do well just with some time to rest and care for them conservatively.
And what is turf toe and how is it treated?
Turf toe is an injury most commonly to the first toe, to the large joint of the first toe. It's an injury to the joint capsule, anywhere from an irritation of the capsule to a tear in the capsule. It's most commonly seen in football players and specifically offensive linemen with having to push off with a lot of weight on that foot. But anyone could potentially get turf toe from pushing off with a lot of weight on that first big toe.
Dr. Hall, how do surgeons confirm the correct side for surgery before starting?
Yeah, that's a good question. We always want to make sure we do the correct side. So there's a common way to do that. In the past, it's been different, and different hospitals had different ways to confirm the proper surgical site prior to surgery. But the American Academy of Orthopedic Surgery a few years back tried to standardize the protocol for confirming the proper surgical site prior to surgery. So what they came up with was that the surgeon would put their initials on the surgical site, and then before the surgery starts, we would have what we call a timeout in the operating room, where everybody stops what they're doing and each person confirms the proper patient, surgical site, and procedure before proceeding with the surgery. And so now it's standardized, and there's much less wrong site surgery because of that. So it's been pretty uniformly standardized across the country to do it a certain way, and every hospital does it about the same way.
Great, good to know. Dr. Rasmussen, what about the mnemonic with the letters RICE, R-I-C-E? How does that relate to the treatment of injuries?
Yeah, that's kind of the mainstay for the conservative management that we've discussed, especially for sprains and strains. And so R is for rest, I is for ice, C is for compression, and E is for elevation. And those simple steps are ways to decrease inflammation and decrease swelling around an injury, and can help lead to more rapid recovery.
Thank you. Dr. Hall, how about the reasons or causes for the need for hip replacements?
Yeah, the most common cause for a hip replacement is just wear and tear arthritis of the hip. And in people who have arthritis, the main problem is that the cartilage wears out. So there's smooth cartilage on both sides of the joint, and it can wear out eventually. And when it wears out, it can cause pain and inflammation and need to be replaced. Other reasons for hip replacement include fractures. When people have a femoral neck fracture that's displaced, oftentimes the blood supply to the femoral head gets disrupted, and so it's not usually successful to try to put it back together and fix it because that won't heal. And so oftentimes in elderly patients we now do a hip replacement for a displaced femoral neck fracture. There's some other reasons why people might need hip replacement. Avascular necrosis is one, and that can sometimes even affect younger people. So one of the reasons why we might do a hip replacement in a younger person is because they get something called avascular necrosis, which means that the blood supply to the femoral head gets disrupted for whatever reason, and then the femoral head collapses and it becomes arthritic at a young age. So unfortunately that can afflict people even into their 20s sometimes. So, and ideally you'd not want to do a hip replacement on somebody in their 20s, but sometimes that's the only option in people who have a really bad hip from avascular necrosis.
Thank you. Dr. Rasmussen, what about the Ottawa ankle rules, and how do they help you in the treatment of patients?
So the Ottawa ankle rules are a clinical decision algorithm that was developed to help primary care doctors and emergency room physicians determine if an ankle injury needs to be x-rayed to determine if it's fractured or not. And so they are rules that are based off of a number of tender points that can be evaluated around the ankle. And then the big one is whether a patient can bear weight on the ankle after an injury or not. If a patient can bear weight and walk on it without significant pain, that decreases the likelihood that there's a fracture. So with any ankle injury, if there's ongoing pain, or specifically if there's trouble bearing weight or walking afterwards, those should definitely be evaluated either in a clinic or emergency room setting.
Thank you. And Dr. Hall, about knee replacements. A caller is asking about a 51-year-old man anticipating both knees being replaced at the same time. What are your thoughts about knee replacement one at a time or both in the same surgical day?
Yeah, there's pros and cons to doing both knees at the same time, or doing one knee and staging them. So with both knees done at the same time, of course you get both knees at the same time, and the recovery period is one time period, and you don't have to go through surgery twice and two separate anesthetics. I think the downside is that the increased risk of complications is real. So the increased risk of blood clots and pulmonary embolism. There's an increased risk of blood loss and requiring a blood transfusion. And plus the recovery is a lot tougher when you have both done at the same time, obviously, because you're trying to recover on two knees and both lower extremities are affected. So I tend to try and encourage people to pick the worst knee first and do that knee, and then once they're recovered from the initial knee replacement, if they still are symptomatic enough, then stage it and do the other one later. I have done it and done both knees at the same time, and some people get through it just fine. But there is a higher rate of complications, and I think patients can do both at the same time. They just have to realize that there's more risk.
And you mentioned the risk for blood clots. What are some of the preventions for blood clots around surgeries?
Yeah, the concern with a blood clot is that patients who have a hip or knee replacement are at an initial increased risk to have a blood clot in the veins of their leg following surgery. And the danger, of course, with a blood clot is that if it gets big enough and it breaks off and it travels to the heart and lungs, it can cause what's called a pulmonary embolism. And a big enough pulmonary embolism can even be fatal. And so we worry about that. Most aren't, and most are treatable, but they can be serious. And so we do a lot of things to prevent blood clots. So we put people on an anticoagulant postoperatively, and there's several that are available. We tend to use aspirin in our practice. It's been shown to be very effective. We also have people wear those tight white TED stockings. Those help to compress the leg veins, and that helps keep the blood from clotting and pooling in the veins. We also get people up and try to get them standing and walking as soon as possible. And that's probably the best prevention for a blood clot after a knee or hip replacement, is to get up and walk and move. So when people walk, every time they take a step, they contract their calf muscles, and when they do, that squeezes the leg veins and it helps move the blood through. And that's why somebody who's up and walking and active rarely ever gets a blood clot. It's people who are debilitated from some medical condition or had surgery, and they aren't walking as much as they normally do. So really the best prevention, I think, is to get up and walk and move, but we use all those adjunct methods to try and prevent blood clots as well. And most of the time we can prevent the blood clots, but we take it seriously, and if somebody shows signs of a blood clot, we evaluate them with an ultrasound, and if they have a blood clot, then we treat that appropriately.
Terrific. Sounds like lots of ways to prevent it, including getting up promptly and moving.
Yeah. And that's where therapy is important. Yeah.
Dr. Rasmussen, how about the stinger injury of the neck? What is that, and how is it treated?
Yeah, that's a good question. It can be kind of a scary injury. It's caused by a sudden injury to the head or the neck, and it would cause pain going down one arm. It's a sharp, burning nerve pain, and that's where the term stinger comes from. But in addition, you can also see loss of function of an arm and a hand with a stinger. So nerve symptoms such as numbness or weakness. Now with a stinger, that should resolve in a short period of time, often in a matter of minutes. If those symptoms were to persist, that would be something that would need to be evaluated with imaging of the cervical spine or of the neck.
Thank you. And Dr. Hall, a caller wants to know, are there age limits to a knee replacement? For instance, could a patient over the age of 80 have a knee replacement done?
Yeah, there's no absolute age cutoff for joint replacement, and we do knee replacements on patients in their 80s. What's more relevant is the patient's overall health. And if the patient's overall health would support a knee replacement, and they're active and healthy and their knees are worn out, and then if the knee is the thing that's really holding them back from being more active, then they're good candidates for a knee replacement. So I think the patients that we see are mostly in their 70s and 80s. And so that's probably, if you get to be older and have more medical comorbidities, that might be a contraindication to doing knee replacement, but I don't think there's an absolute age cutoff.
Dr. Rasmussen, how about glucosamine? Is it good for building up cartilage and strengthening bones?
There's mixed evidence on glucosamine. I think overall the evidence is weak. It is used by patients, glucosamine, chondroitin, to try to preserve cartilage. It's not something that's going to build back cartilage. I usually tell patients it's worth a try if you have arthritis of a major joint, such as a knee. It's probably worth a try, maybe a month's trial of glucosamine chondroitin to see if it helps with your symptoms. If it doesn't help with your symptoms, it might not be worth continuing to take.
A caller from Minneapolis wants to know, after having 2 hip replacements years ago, how might they know whether they need to get one of them replaced? What are some signs and symptoms to?
Yeah, so if the hips are still functioning well and the patient's asymptomatic, then they probably aren't going to need to have a revision. If they start to have pain that wasn't there before, or if there's some drastic change in their level of function, then I think it's worthwhile to have it evaluated. And the first step in evaluating the hips would be to get x-rays. And if there's any concern on the x-rays, maybe even further imaging with a CT scan. But I think if the patient's asymptomatic and they've had hip replacements, there's not likely anything wrong. If they haven't been seen or evaluated for it for a long time, it might be worthwhile to see an orthopedic surgeon, get a set of x-rays and just make sure that everything looks good on the x-ray. But the hip replacements nowadays can last a long, long time. And so a patient that's 20 years out from a hip replacement might be doing just fine. And if they're asymptomatic, they probably wouldn't need anything further done.
Thank you. Dr. Rasmussen, a caller wants to know, what are the best ways to treat shin splints?
Yeah, shin splints are actually on kind of a continuum of stress injury to the bone, to the tibia in the lower leg. And shin splints themselves can be treated conservatively with what we discussed earlier: rest, ice, compression, elevation, and altering the amount of activity you're doing. So, for example, if you just picked up running and all of a sudden you've developed shin splints, you're probably going to want to back off on the volume of running that you're doing, take a break, rest, and kind of gradually build back up. So it's an injury that can be managed conservatively, and some modification of your activity should go a long way.
And a question now on outside injuries. What are the outside injuries associated with the eyes?
Well, a primary one would be, eye trauma. If you're struck with an object in the eye, if you were poked with something in the eye, those are things that we are concerned about. I think in that scheme of things, advice that we give to patients would be, if you have any sort of persistent blurry vision after an injury like that, or pain associated with it, that's definitely an injury that should be evaluated. That would be our primary concern for outdoor injuries involving the eye.
Dr. Hall, what about knee dislocations? How do they occur and how do you treat them?
Yeah, knee dislocations are a very serious injury. If you have a tibiofemoral dislocation, that usually involves a high energy injury. That means usually trauma from a car accident or a serious fall or a sports injury. A more common dislocation in the knee is a patellar dislocation, and that's less serious, but a patellar dislocation is a dislocation of the kneecap. And that's a more common sports injury. So what happens typically, if this is the way the knee is lined up, the patella can dislocate to the lateral side. And so if it does, sometimes it'll spontaneously reduce with just straightening the knee and it'll go back in place. But sometimes it remains dislocated out to the side. And if it does, then that needs to be seen probably in an emergency room and put back in place. And so that's a less serious injury than a knee dislocation, which means a dislocation of the joint itself. The danger with an actual knee dislocation is that it can disrupt the arterial supply that runs down the back of the knee. So the big worry with a knee dislocation is an arterial injury that would compromise the circulation to the leg. So those are two different things, but they're both considered knee dislocations. So a more common sports injury would be a patellar dislocation by far, and that's a common thing. And so we see those frequently. And when they happen, we usually put it back in place and treat it conservatively. And then if it were to become a recurrent problem, then sometimes surgery is required to stabilize the patella and keep that from happening.
Thank you. Dr. Rasmussen, a caller who works standing on his feet quite a lot wonders about bunions and how they might be symptomatic and could be treated.
Yeah, bunions are bony protrusions or malformations, again, off of that first big toe joint, and they can develop over time. They would cause pain right at that site. Most of them can be managed conservatively with trying to wear a wider toe box shoe and sometimes providing some additional support underneath the bunion. If somebody were to have persistent pain beyond those conservative measures, it might be a good idea to get x-rays and to be evaluated either by an orthopedic physician or a podiatrist.
A caller asks about local knowledge or expertise regarding metal allergies in anticipation of joint replacement.
Yeah, metal allergies are rare. The most common metal allergy is to nickel, and it is a concern sometimes because some of the prostheses that we use do have nickel in them. That's been recognized as a common metal allergy, and so there are alternative prostheses that we use that don't have nickel. If somebody is really concerned or has a history of a metal allergy, we do allergy testing ahead of time. And if they do have a true allergy to some of the metals that are used in the prostheses that we have available, we look for other alternatives. And so a lot of patients that maybe had a reaction to some type of jewelry or some other metal, a lot of times that's a nickel allergy, and so we test them for that. And if they have a nickel allergy, we have alternatives that we can use that don't have nickel, and so we can work around a lot of the metal allergies.
Dr. Rasmussen, considering the incidence of concussion in sports, how has the evaluation and treatment of concussions improved in recent years?
It's improved quite a bit, and our understanding of it has improved a lot. There's been a lot of research done on concussion over the last 5-10 years. The old standards of practice where when somebody would get a concussion and would oftentimes be told to go in a dark room and to basically rest there until the concussion had resolved, or the flip side of the concussion going unnoticed and an athlete or sports participant being put right back into a game. We don't do those things anymore. So number one, if somebody is suspected of having a concussion during an athletic event, we will immediately remove them from participation and manage it as such. And the mainstay for concussion management is still rest. It's brain rest. Concussion is not a structural injury to the brain. If we do neuroimaging, either a CT or an MRI of a patient with a concussion, we won't see any damage. It's a functional injury to the brain, where the brain has been jarred within the skull, and it needs time and rest to get back up to full processing speed. You can kind of think of it like a computer that has locked up on you, and you need to reboot it, and you need to give it time to restart. So the mainstay, though, is still rest. But nowadays, rather than saying you got to rest in a dark room for 2 weeks, we say rest, but as soon as you feel like you can tolerate it, we like to advance people back gradually to activity and their normal daily routine. We still have what we call a guided return to play protocol for youth and for athletes, where we will not allow them to get back to sport, usually within a 7-day time frame, and that allows for a stepwise fashion to make sure they're tolerating a graduated advancement of their activity before we're putting them at risk for potentially getting to be in a contact situation again where they might get their head injured.
A few brief questions to wrap up. One caller described an injection of fat into the knee joint. Can it occur again, and how often?
An injection of fat into the knee joint. I'm not sure.
I think they're within the field of what's called regenerative medicine. There are people that are exploring the idea of using fat cells as a way to preserve cartilage. I don't know if there's really any good evidence supporting that, though.
Dr. Hall, what keeps the ball in the socket of a hip that has been replaced?
Yeah, so part of it is the geometry of the hip that keeps it stable, but part of it is the muscle tension. So your muscles contract and it kind of holds the hip in place. And so when you do a hip replacement, it's important to get the parts positioned correctly, because if the parts are not positioned correctly, it can lead to more problems with instability. So it is possible to dislocate a total hip replacement, and that happens sometimes. And when it does, we can usually put it back in place. But if there's a structural reason for it dislocating, such as the parts maybe being malpositioned, then sometimes you have to revise it to get it back in place. But most of them are pretty stable, and so and more stable than the old versions of hip replacements used to be. So people can be pretty active. They can do a lot of things with hip replacements. We usually try to recommend that people don't get their hip in a real awkward position, because if you get in a real awkward or extreme position, it can put you at risk to dislocate the hip. But they're pretty stable, and the muscle tension is what really keeps it together.
Great. Well, I thank you very much, and I want to thank our panelists, Dr. Patrick Hall and Dr. Carl Rasmussen, and our phone volunteers from WDSE. Please join host Dr. Ray Christensen for a program on end of life and advanced care planning, when his panelists will be Dr. Jeff Koopman and Dr. Amy Greminger. Thank you for watching. Good night.